attending the Office of Health Strategies virtual forum on using the cost growth benchmark as a tool to improve healthcare affordability. Today, you're going to hear consumer perspectives on healthcare affordability and see data that supports why addressing healthcare affordability is so important. You will hear how critical it is that we apply an equity lens to this work and all of our collective work. We will also give an overview of the cost growth benchmark and other related initiatives intended to address these issues and share with you our preliminary cost growth driver findings. We'll conclude with a very good panel discussion on collaboration on these efforts with representatives from providers, insurers, hospitals, and employers. So with that, I want to first say and announce that unfortunately, our First Lady, Annie Lamont, had a last-minute scheduling conflict and was unable to attend today, but we were lucky to ask and get Rachel Block from the Milbank Memorial Fund here to make a few remarks. I just want to introduce Rachel before she makes those remarks. Rachel Block is a program officer at the Milbank Memorial Fund, where she focuses on a variety of state health policy issues. She previously served in numerous executive roles in the public and private sectors, including as a deputy commissioner for health information technology transformation in the New York State Department of Health, where she spearheaded the development of New York State's health information technology strategy, and as the founding executive director of the New York eHealth Collaborative. Ms. Block has also worked at the Centers for Medicare and Medicaid Services, affectionately known by all of us as CMS, where she held several senior management positions directing policy development and operations for Medicaid, the state's Children's Health Insurance Program, CHIP, and federal survey and certification programs. She was the founding executive director for the Vermont Healthcare Authority and had senior health policy staff roles in the New York State Legislature. So Rachel, welcome, and thank you for making some remarks this morning for us.
Well, thank you very much, Vicki, and it really is my pleasure to be here. I'm sure that the First Lady is disappointed not to join you today because this is such an important meeting and such an important initiative, but it is my pleasure to provide a little bit of context and a very brief introduction to the work that you'll be discussing during the rest of this meeting. I hope you're familiar with the Milbank Memorial Fund. Oh dear, let me reverse my, sorry. This is Zoom.
We do see you. We see you speaking.
Yes. But Milbank was backwards, and that is not allowed. Sorry about that, folks. The fund, I hope you know, is committed to connecting leaders with the best evidence and experience to improve population health. And we do this work by literally connecting leaders, people like Vicki and her team, to others around the country who are doing similar work. And we also provide states with assistance to develop and to implement evidence-based models that will improve population health. And that was really our entree to beginning our work on sustainable healthcare costs a few years ago. We think this work is important because healthcare cost growth is placing enormous pressure on our ability to support population health in a few different ways. First, I think everyone recognizes that healthcare cost growth consistently has exceeded growth in the economy. And this has implications for the state, it has implications for employers, and it has implications for households. It means that there is more to spend on healthcare, but perhaps less to spend on other essential things like education, childcare, and housing. The second reason we think this is important is because we have a lot of information about healthcare quality, thanks to years of efforts to standardize measures in that field. But we really know surprisingly little about healthcare costs, and specifically the value for our healthcare spending. More analysis and transparency can open the door to answer key questions about what we get for our money today. The third reason this is important is this focus on sustainable healthcare costs will provide a baseline to begin the process to identify the most promising opportunities to get better value. Once we have ascertained what we think is the value for what we're spending today, we can then begin a rigorous process to determine how we want to have better value. Things that have the greatest potential to improve health. Healthcare areas such as primary care, and outside of healthcare, such as housing supports. The governor tasked the Office of Health Strategy, Vicki and her team, to implement a rigorous process, of which this meeting is just one small part of the many, many efforts that they have been implementing so far, which is a rigorous process to engage stakeholders and the public to set a target or benchmark for healthcare cost growth, and then to identify the specific opportunities to reduce healthcare cost increases. Some states have called this a target, some states have called this a benchmark, but I think as you'll hear in a little bit, essentially we use these terms interchangeably. I'd just also like to emphasize that this concept of the target or the benchmark is a goal. It is not a hard and fast standard that is somehow applied just uniformly in one way or another. It is a goal, something to strive for, and something to measure the system's performance against. Milbank, with support from the Peterson Center on Healthcare, is now providing technical assistance to 5 new states leading these efforts, of which Connecticut is one. And these efforts include measuring and acting on healthcare spending trends. By connecting these leaders to the best evidence and experience in this field, the fund is supporting Connecticut to give the public more information about health spending. Where does it go? What are we buying? And to identify policies to move health spending to a more sustainable and value-driven path. It is at its heart about better information and evidence-based policy, data-driven policy. And we are extremely proud to be working with Connecticut on these efforts. So Vicki, that's my introduction. And if there's time, I'm happy to answer questions, but I think you have a big program.
Oh, thank you so much, Rachel. So we appreciate so much the support of the Peterson Milbank program for sustainable healthcare costs. That's going to be critical to OHS in the state of Connecticut. Appreciate you getting on this morning to share those comments. So thank you. And now we're going to hear from 2 individuals who will help frame the issue of healthcare affordability through their unique lenses. First, we're going to hear from Angela Harris. I want to introduce Angela. Angela serves as a patient representative on the OHS technical team. She serves as the chair of the Phillips Health Ministry at Phillips Metropolitan CME Church in Hartford. And she's focused on improved health, well-being, and equity for communities of color in Hartford, especially in the North Hartford Promise Zone, and across the region through her participation in the Ministerial Health Fellowship Advocacy Coalition, addressing statewide policies and systems. Good morning, Angela. Very happy to have you here. So I'll turn it over to you.
Good morning, everyone. I would just like to start by thanking you all for the opportunity to share today with this illustrious panel. I would also like to thank the governor for his executive order number 5, which brought us all to this very important work. I just have an overview to share with you today, which allows us to look at the broader picture. By being on the technical, the cost growth benchmark technical team, I was able to look at the data and analysis that's being done. And thanks to the executive order, we are trying to provide measures and metrics for improvement. As we drive costs down, we're also looking to increase efficiencies and ultimately increase the quality of care. The many factors that go into the ecosystem are, of course, the patients, but there are providers, state agencies like DEMIS and DPH and Office of Health Care Strategy. There are payers along the system, as well as community-based agencies and even employers. Everyone has a role to play. The multiple contributors to the overall healthcare costs impact individuals. However, individuals can impact their own care by taking care of preventative services and screenings rather than delaying care, which during this pandemic, we found many people have done. There are things that the insurance companies can do to provide affordable packages with reasonable co-pays and deductibles. The various agencies can change systems to promote efficiency and effective use of coordinated healthcare in person-centered, patient-centered medical homes. And even our community-based organizations and churches as trusted messengers can connect people to services and provide critical information so that people can be informed to take full advantage of the opportunities that exist so that they fully utilize all that the central benefits that come with their insurance coverage. As we know, there are hard to reach populations that still remain uninsured. And we're looking to folks like Access Health Connecticut to get boots on the ground to connect with folks so that no one goes uncovered, particularly in the midst of a pandemic. Providers can take costs out by accurate coding and consolidated services and treatments so that a single visit within a medical home, a patient can actually get multiple services in one-stop shopping situations. Bottom line, reducing costs doesn't mean we're willing to relinquish quality. Improvements in efficiency can also raise the quality of care, and I can't drive home that point enough. We are the state of Connecticut. It's a tale of two Connecticut's. We have one of the highest per capitas in this nation, yet we have pockets and communities that are suffering and not receiving the benefits of being in the great state. Calling our attention to driving costs out of the system and actually looking at ways that we can all partner and make our systems run smoother and talk to each other and allow providers to log in once and take care of prescriptions and medical records and medical history. Like those, there are a lot of things that we can roll up our sleeves and get done. And at this time, when we have federal dollars flowing into the state, I would hope that we could all take advantage to use the resources widely and ultimately make sure we have equity baked into everything we do so that no one is left behind. I'd be happy to answer any questions when we get to the panel, if anyone has any for me. But again, I appreciate the opportunity. And lastly, I would like to thank other partner agencies like Connecticut Health Foundation and the partners that we have at Health Equity Solutions who are continuing to draw the attention to raising and lifting up the community's voice so that consumers have a role to play in this very critical work. Thank you.
Thank you so much, Angela, for joining us. We appreciate your comments very much, and they will better inform, I think, the panel discussion that's coming up soon. So thank you. And with that, I want to introduce Susan Millerick, who serves as a patient representative on the OHS Stakeholder Advisory Board. Susan manages a chronic condition and the care needs of an active family. She's experienced both the rising cost and narrowing benefits of employer-sponsored healthcare, the extreme costs of COBRA coverage and healthcare services without coverage or network discounts, and engagement with Access Health CT. She believes healthcare costs need to be understood, measured, and reported against to fuel better and more informed decision-making by all stakeholders. what we know and understand, we can address and manage. And I've heard Susan say that many times, and I'm going to let her speak in her own words. So I'm going to turn it over to Susan. Thank you so much, Susan, for joining us.
Thank you, Vicki, and thanks to all of you who are taking the time to join us today. And I'd also like to say, I'd like to just, I think, really point out my gratitude to the state of Connecticut for all that it has done to try to embrace healthcare quality. And especially in this last year, I got my first shot yesterday. I am thrilled about that. And I am grateful to everybody who is on this call and who has worked in the background to make Connecticut a leader in the management and the rollout of the vaccination to so many people so quickly. And I'd like you guys to really think about leadership in this area of managing costs and quality in much the same way, by coming together, by uniting behind the issue, and by making sure that we have the data that we need and that we use the data that we have to really understand what's driving healthcare costs. In the last 14 months, due to a series of factors in our lives, my husband and I, we spent out of pocket over $66,000 on healthcare alone. That's more than a mortgage. That's more than my daughter's college tuition. That's more than my son's high school tuition. That's a huge amount of money. And it's why there are so many people going into personal bankruptcy today because of healthcare costs, which, as you know, are the leading cause of bankruptcy. The costs to manage healthcare, the cost to have quality healthcare when you're a type 1 diabetic is extraordinary. The standard of care is insulin pumps, continuous glucose monitors, insulin, which you've all confronted the cost of insulin. To get the best quality care, to have the best outcome, you have to spend a lot of money. And I really was exposed to exactly what that was over the last 14 months or so. And so, something has to give. I think that when we think about how we pull together on this, we have to remember that this impacts everybody. We're all just steps away from a change in our lives that can leave us without healthcare benefits. If you work for the state, I think that's probably hard for you to imagine, but it happens, and it happens to people all the time. And it happens not just in our inner cities, but it happens in our suburban communities, and it happens everywhere, where you can be rolling along through life doing just fine, and then all of a sudden you're this far away from Medicaid, and you're wishing you could qualify for Medicaid because you could be sure your kids are going to get the care they need. But you can't. So you're just above that line, and you're doing the best you can to juggle all of this and manage debt and manage all the expenses in life. And healthcare is this overwhelming problem that you can't not have. So you have to do whatever it takes, and you have to borrow from Peter to pay Paul. And that is not a situation that's sustainable for the very poor, who might not have access to credit cards and family members and others who can help them through. Or in our case, to be very frank, a 401k to raid so that you can manage to pay for healthcare for your family. Because if you don't take care of your healthcare today, you're not going to be here to enjoy that 401k in retirement. These are real decisions that a lot of people have to face. They're difficult and they're painful, but at the end of the day, there's not really a choice. And it even happens when you have healthcare. So, you know, it's Murphy's Law. I guess we could say 'tis the season in March, but when we were finally able to join the Access Health Connecticut plan, and we chose a high deductible health plan, we were eligible for the subsidy, which was fabulous. And it brought our $2,700 a month COBRA bill down dramatically. And that was so helpful, except then my 17-year-old son went out and fell skiing and broke his collarbone. So there you are, needing surgical repair, and you have no coverage until you've paid all of the out-of-pocket maximums. So again, $7,000 right out the door on his healthcare urgent care, doing all the right things, not going to the ED, going to urgent care, getting in with the right people and getting him surgically repaired is how we started off the year. So I guess I'd like to just say that what we've been doing all along is important. And I do believe we have a very strong quality of healthcare in Connecticut, and we're lucky in the Northeast in general to have a very strong, high quality healthcare service, but something's got to give. And we need to be willing to look at things differently and do things differently and decide jointly that this is something that's no longer acceptable, that healthcare is such a huge burden on the American public. If Connecticut can lead on COVID, Connecticut can lead on cutting healthcare costs and keeping quality constant. And I'd like to thank you very much for your commitment to seeing that happen.
Thank you so much, Susan, for sharing your story, which really brings us back to why we come to work every day and why the people here that I think you're going to hear from on the panel come to work every day. We've got to take this on together. We've got to own this issue, and we've got to collaborate to address this very real issues that impacts everyone's lives every single day. So thank you again so much for joining us this morning.
My pleasure.
And I hope things continue to work out a little better for you in the future. And now I'm going to turn this over to Michael Baylett, Michael Baylett of Baylett Health. Baylett Health has been working with us for about a year now and is also working with us in the context of the Peterson Milbank program. And Michael Baylett, who's the principal, may be known to many of you who are watching today, but he's going to provide a presentation on out-of-pocket trend growth. And so, Michael, I'm going to hand it over to you.
Thank you, Vicki, and good morning, everyone. I thought that the narrative that Susan just shared and Angela's comments that preceded Susan really show that high healthcare costs are not an abstract concept, but there's really direct personal impact from having high healthcare costs, and high healthcare costs are growing really quickly. So you just heard from Susan and Angela sort of a personal narrative about healthcare costs. I want to share with you now what the healthcare spending problem in Connecticut looks like in numbers. And I'm going to take just a few minutes to do so. So healthcare affordability is a major problem for two reasons. Healthcare costs in Connecticut are among the highest in the country across all of the states, and they're growing much faster than personal income, which means that year after year, the percentage of take-home pay that's going to pay for healthcare is increasing, and there's less money that people have for everything else in their lives. It's a bad problem, and it gets worse year after year after year after year. It is unrelenting. So, I want to show in just a couple of graphs the problem of, number one, of high healthcare costs relative to the rest of the country and of fast cost growth. So here's data on healthcare spending in Connecticut in 2009, 2014, and you can see Connecticut has been in the top 5 of the most expensive states for healthcare in terms of spending per capita for both of these time periods, and significantly above the median value that you see in both years. In terms of growth, this problem is, I would say, equally, if not more, vexing. Since 2000, Connecticut worker contributions to employer-sponsored insurance have grown 2.5 times faster than personal income. It's an astonishing rate of growth. So let's take a look at spending growth in a little bit more detail, looking at a recent 4-year period. This is data that I'm going to show you that's been mined from Connecticut's All Payer Claims Database, which is a database that collects claim data from insurers, from the Medicaid program, and from the federal Medicare program. So the analysis I'm going to share with you focuses on commercial spending, and this is primarily people who are fully insured, as opposed to are getting coverage from their employer who's self-insuring, although state employees and their dependents are included in the analysis. So what we know is that between 2015 and 18, spending grew 15% or almost 5% a year. This analysis excludes retail pharmacy spending. And we know from other states that retail pharmacy spending growth rates have been quite high. So in fact, if we include retail pharmacy spending, it's possible that this 5% per year could be even higher. What I want to draw your attention to in the notes on this slide is note number 6 here. Average wage growth in Connecticut during this time period was 1.47%. So compare that to spending of 4.9% a year. And we can see that people with commercial coverage are losing a portion of their take-home pay every year, and by a significant percentage. I also want to note that that 4.9% spending is also above state economic growth, or the state domestic product, which means that this spending growth rate exceeds growth in state tax revenues in all likelihood. But as bad as this looks for consumers, it's actually much worse. And so I want to show you now what the growth rate looks like for consumer out-of-pocket spending. So as Susan just shared, people with commercial insurance don't have all of their healthcare expenditures covered by the insurance policy. Rather, there are large deductibles, co-insurance, and co-payments. And so when we look at the growth in spending for consumers for those 3 reasons, deductibles, co-insurance, co-payments, we see that the growth rate was 26% over those 3 years. That's about 8% a year. And remember, wages were growing 1.47% a year. It's an astonishingly high rate of growth. So why was it happening? A couple of reasons. Employers faced with very high healthcare costs have changed their plan design as a means to lower premium growth. So an insurer might say, well, your premiums are going to grow 14% the next year. And so the employer might say, well, I'm going to increase my deductible so that the premium doesn't grow as much. And so if the deductible gets larger, that means that out-of-pocket spending for consumers are going to get larger. In addition, consumers like Susan, faced with different products to choose from, will see stark differences in premium contributions for different types of coverage, and they might choose to opt for a high deductible plan because the premium contribution, or the premium, is going to be much lower. So both employers and consumers are picking plans that have higher out-of-pocket spending as a way to control the growth in premiums. So I think that these numbers provide some quantification of the personal narrative that we just heard from Angela and Susan, and we can see here in data exactly why Susan's story resonates, because we see this factually in the data that's been collected.
Okay, thank you, Michael. And I'd like to see if we could advance the slide deck a little bit. I'm going to talk a little bit about healthcare affordability and the main initiative we're talking about here today. If we could advance the slide, one slide, thank you. Part of OHS's strategic plan is to address healthcare costs and quality on the systemic and household levels. Briefly, I just want to touch on this definition of affordability that you see here on your screen, which applies not just to the work we're doing on the healthcare cost growth benchmark, but also on a healthcare affordability index initiative. So we've adapted this affordable healthcare definition across all of our work at OHS. I want to touch briefly on that affordability index initiative. This is a tool which is going to help us inform how healthcare policies has developed affect the ability of Connecticut residents to maintain quality healthcare coverage and meet basic economic needs. So we will have another event next month soon with our partners on that work, to include the Comptroller, the Connecticut Health Foundation, and the Universal Health Care Foundation, to talk more about how we can address affordability. Now I would like to turn to the main initiative we're addressing today, which is Executive Order number 5, which Governor Lamont signed in January 2020. The executive order has 4 major deliverables, as you can see on the screen. The first one is the cost growth benchmark that we're talking about, setting a target that payers and populations and providers would like, that we would like to shoot for a rate of spending growth that we think will be more manageable and more affordable for the residents, employers, and like across the state. The second part of the order that we haven't talked about much, and I hope the panel will also talk about, is a primary care spending target. There's lots of literature that shows that increasing the share of spending on primary care spending can not only improve healthcare costs or the rate of healthcare cost spending growth, but also can improve overall healthcare. It was really important to us to shoot for a target, and again, a target that is a rational target that we think we can achieve. Right now, Connecticut is spending about 5% by any number of estimates on its total share of healthcare spending on primary care. Although our Medicaid program is much higher than that, we are still way below 10%. There are states around us that are already, Rhode Island, for instance, has a target of higher than this for its commercial spending. And there are states like Oregon that are already above 10% on their primary care spending as a share of total health care expenditures. We think it's really critical that we shoot for that. The third part of this executive order that we're touching on today, and Rachel talked about a little earlier, and Michael just highlighted, is the data use strategy. This is a complementary strategy. We will leverage our all payer claims database, which OHS hosts, in which we have millions and millions of healthcare claims, to do analyses on particular cost drivers of healthcare. And we will bring those analyses to our technical team or to a group of experts to analyze and help advise us on where we can work together to target strategies to improve our healthcare spending and bring that rate of spending growth down to help people achieve the target. We don't expect people to have to do this on their own while we sit back and watch. We want to make this a collaborative effort and work with our providers, our carriers, our consumers, and people across the state to rationally address the rate of spending growth. And lastly, something that's really important to us that's in the executive order is setting quality benchmarks. Connecticut will be the second state with an executive order or with a cost growth benchmark that actually will look to setting quality benchmarks. That will beginning next year. We're actually in the process of setting those quality benchmarks now. We think that's critical because cost and quality are hard to separate. And while we do have really good quality in Connecticut, it can be better. And we need to also focus, when we're focusing on our quality of care, our primary care spending, and our overall healthcare spending, we need to, as Angela said, put that equity lens on it. So the work we're doing in the Office of Health Strategy and with our partners on the technical team and the Stakeholder Advisory Board is to complement all that data strategy we have with stratification of our data by race and ethnicity so we can better measure how we're doing as a state and improve our efforts. So with that, we've made a lot of important decisions so far, including setting our first year's cost growth benchmark and the first 5 years, in fact, of the cost growth benchmark, an initial primary care spending target, and as I said, in the process of the quality benchmark. So again, I want to thank the technical team and Stakeholder Advisory Board and everyone else who's advised us and helped inform us on our progress to date. We've really made important decisions based on their feedback and input, including a strategy to help us monitor potential adverse consequences of implementation of the cost growth benchmark. So now I'm going to turn it back to Michael and to Paul Lombardo, who I want to introduce. Paul, he's the Connecticut Insurance Department Director of Life and Health Division for the last 3 years. Prior to that, he was the Chief Health Actuary for 21 years. He's also a member of our technical team and someone I turn to all the time for advice and conversation about the work we do at the state. We're going to do a little bit of a review on selected cost growth drivers in Connecticut based on the preliminary data analysis Michael just shared with you. So I'll turn it back to Michael and Paul.
Thanks, Vicki. So as Vicki indicated, we're going to examine a little bit how do we understand the contributors to high healthcare spending and to high cost growth. I'm using cost and spending here as synonyms. We care about this because we can't correct the high rate of cost growth and the high rate of spending if we don't understand what's contributing to it. And so the cost growth benchmark is intended to serve metaphorically as a beacon that we can use through collective action at state, payer, employer, provider levels to influence spending growth. But to influence spending growth, we have to understand why healthcare spending is high, how it is variable across the state, and what's driving the spending growth that I described earlier is happening year after year after year. So the data use strategy that Vicki just described is really central to it. And that means using that all payer claims database and other data resources to gain insight. And once we gain insight, then we can bring together stakeholders to convene and collaborate on how best to address spending growth to meet the benchmark. And in fact, in some of the other states that have cost growth benchmark strategies, that's what they're doing right now, is identifying what are the strategies that will address the cost drivers within their state. So this past fall and early in the winter, OHS directed a contractor to perform an initial analysis of the all payer claims database, along with some databases available through the US Census Bureau. And there's a lot more analytic work to be done, but the analysis that was performed did provide some insight into what cost growth drivers are. And so Paul and I are going to share just a few preliminary insights. There were others that came out of the analysis as well. And there will be more to follow when the scope of the analysis expands in the coming months. So there's more to learn, as I indicated, but we can identify at least 3 contributors that are having a substantive impact on commercial healthcare spending and its growth. These are likely also to be having some impact on Medicaid and Medicare spending as well, but the analysis performed thus far is just focused on commercial spending. So retail pharmacy spending is one contributor that we've identified. This is not specific to Connecticut. It's common across every state. And I want to distinguish retail pharmacy spending from what people sometimes refer to as medical pharmacy. So medical pharmacy is spending that's related to physician administered medications. I will note that spending for growth for medical pharmacy is growing even faster than retail pharmacy. But for today, we're just focusing on retail pharmacy, which is the traditional way in which most of us obtain pharmaceuticals. 2, hospital spending is certainly a contributor that's emerged through the analysis. And then 3rd, the prevalence of chronic illness in the population is a 3rd contributor. None of these, I think, are probably surprising to people who are in and around healthcare and health policy, but there's some real value in being able to quantify the impact that these contributors have, because that can serve to galvanize necessary action to address those cost drivers. And again, as I noted, we need to get insight for Medicaid and Medicare, and OHS plans to do so in the future. So I'm going to look to Paul first to talk about retail pharmacy spending and a little bit of data that the insurance department's collected. And then I'll talk about what analysis of the all payer claims database revealed about hospital spending and chronic illness prevalence. Paul?
Great. Thank you, Michael. Hello, everyone. Just to give you a sense of what's happened with regard to prescription drugs and retail pharmacy and the impact on insurance premiums over the last 10 years. About 10 years ago, prescription drugs were about 11, 12% of total health insurance premium. Right now in 2021, it's quickly approaching 25% of the total health insurance premium that an individual pays today. annual trend over those years has been between 10 and 12%. Sometimes it's been as high as 16, 17% annual trend. And other years it's been single digits, high single digit trend for prescription drugs. So it is growing as fast, if not faster, than any other component in the health insurance premium development. And it is therefore is becoming a larger and larger portion of the health insurance premium that we're seeing. And this data is readily available. We make all of our rate filings that carriers submit. They're all public information. They're on our website. It's a fairly easy way to navigate to get to this data. I will say that prescription drug trend, pharmacy trend is made up of two components, really. It's the cost and it's also the utilization. And we are going to take a deeper dive at the department in looking into these numbers to see if we can attribute that 10 to 12%, what percentage of that is from utilization of prescription drugs and what percentage of that is from the cost. Because the carriers provide utilization and unit cost data for prescription drugs to the department within their rate filings. The only other piece I will talk about today is Public Act 18-41. It requires carriers, health insurance carriers, to provide a significant amount of data with regard to outpatient prescription drugs in Connecticut. We are going to see our first submission more than likely at the same time as the rate filings come in at the beginning of July of this year. And it's a whole array of data. It includes the 25 most frequently prescribed outpatient prescription drugs. It identifies, it identifies the 25 outpatient prescription drugs with the greatest cost by total annual spend. It'll also identify 25 outpatient prescription drugs with the greatest year-over-year increase in cost based on total annual spend. It identifies the portion of total premium that brand names, generic drugs, and specialty drugs make. Just another anecdotal set of data. Specialty drugs make up about 1% of the utilization of prescription drugs, but account for about 40% of the cost, overall cost of prescription drugs. We are also going to be able to identify the annual increase of brand name, generic, and specialty drugs year over year. We will also get data broken out by outpatient prescription drugs, inpatient medical, outpatient medical, professional, and other year over year annual increases that they will identify. The name of each outpatient specialty drug that's covered, and the 25 most frequently prescribed prescription drugs for which a rebate was received by pharmaceutical manufacturers. We also are beginning to receive data, and we'll be reporting on that data early next year on some PBM information, specifically the total amount of rebates for Connecticut policyholders in commercial fully insured plans, and what percentage of those rebates get passed on to the health insurance carriers, and what percentage of those rebates on an aggregate basis stay with the PBMs. So we are going to be getting a significant amount of information in the next 6 months to a year that we are going to be able to begin to report on and provide specifically to this group as well. And that's it. Thank you, Michael.
Yeah, thanks, Paul. All right, so let me quickly highlight what's going on in terms of hospital spending and chronic illness prevalence, and then we'll move on to our panel. So hospital spending. So what we know is that for commercial hospital spending, we had annual growth of 6.9% per year between 2015 and 2018. And you can see some broad service categories of that include professional spending, and then these three categories of hospital spending. Professional spending growth was pretty modest, 2.7% per year, but the hospital spending growth was quite high. And hospital spending was really the primary contributor to commercial healthcare spending growth. Again, absent pharmacy data, which we don't have in this analysis. And based on the data that Paul just shared, we certainly would expect pharmacy spending growth to have appeared significant here in this analysis. But the growth rates of near 7% a year, again, think back to wages growing 1.4%. These are pretty high annual rates of growth. So why is it more use of services, or is it higher cost per service? Well, so we have a subsequent analysis, and you can see in the far right column here that utilization of services actually for hospital services declined or increased a little bit for non-ER outpatient services. So it wasn't an increase in volume, it was an increase in spending per unit. Now, spending per unit can be either a mix of services, so maybe more expensive services are delivered more often and less expensive services less often, or maybe actually it's the price paid per service. And while not on this slide, we did some additional analysis that showed that of these annual percentage changes in spending per unit, that's what you see in these middle columns right here. About 1/4 was due to a change in service mix, so more expensive services, and 3/4 was due to actual changes in prices per service unit. So this is another insight that we've gained so far. What do we do about it? Well, that's work to be done, but we have now some quantifiable, explicit insight into what has been driving healthcare spending growth. And here we can see this graphically that over these 4 years, that spending per inpatient admission grew while utilization actually dropped. All right, and the third category of cost growth driver is chronic illness. Chronic illness prevalence in the commercially insured population in Connecticut is quite high. If you look at the bottom here with this red font, you can see that almost 1/2 of all adults, and this is just for adults, no children in this analysis, almost 1/2 of all adults have one of 27 different chronic conditions, and about 1/4 have two. And if you look at the spending, PMPY is per member per year, so this annual spending. If you look at all members in the top right column here, it's about $6,100 per year. But if you look at people with chronic conditions, it's significantly higher. And so there's no question that the prevalence of chronic conditions among adults is contributing to higher spending. And as prevalence of chronic conditions grows, so should we expect spending to grow. And then one last slide, we can see here that for those 25% of insured adults who have a chronic condition, who have two chronic conditions, there are certain combinations of chronic conditions that often go together. So, for example, 1/2 of all people who have hyperlipidemia, which is high cholesterol, also have hypertension, which is high blood pressure. And so lots of combinations of chronic conditions that not only, of course, limit the health status and the lifestyles of people who have chronic conditions, but certainly also drive up healthcare spending. Okay, so that's a quick overview of just some of the data that we have that gives insight into healthcare spending. As I said, there will be more analysis coming, but I think for now, that's all we're going to share. We're going to switch over to our panel.
Okay, thank you so much, Michael. I want to let people know who are listening or watching, these slides can be up on our website, and obviously this recording will be made available. So anybody who wants to see this can see it afterwards. I want to get to the meat of our discussion today, or additional meat to our discussion today. And I want to introduce Luis Perez, who will be moderating our panel today, which is going to focus on affordability through collaboration. Luis Perez, LCSW, licensed clinical social worker, is the president and CEO of Mental Health Connecticut. He's held leadership positions both in the private and public sectors. He's also served on numerous boards, task forces, and committees at the local, state, and national levels to improve overall health and access for all. Known Luis for a long time, and he's a great guy, and I'm very happy that he's agreed to moderate today. So I'm turning it over to you, Luis. Thank you.
Thank you so much, Vicki. Appreciate those kind words. And it's my task to introduce and welcome our panelists, and want to thank them for joining us this morning. I think they bring a wealth of various backgrounds and perspectives to this conversation. So I am hopeful that we will shine some light and at least explore some important aspects of the work ahead of us. Let me start by introducing Dr. Bennett Alvarez. Dr. Alvarez is a gynecologist who came from the Cleveland Clinic 2 years ago to assume the role of president and CEO of Pro Health Physicians, the largest non-hospital affiliated primary care group in the state, with over 80 locations and taking care of approximately 10% of Connecticut's population. He brings a physician's perspective to the conversation today.
Thank you.
We
Luis.
also have Dr. Emmanuel Kentabibi. He is the president of the Connecticut Academy of Family Physicians, faculty at Middlesex Hospital Family Medicine Residency Program, as well as the chair of Safety and Quality Improvement at Middlesex Hospital. And as if he wasn't busy enough, he's also assistant professor at the UConn Frank Netter School of Medicine. As a family physician, he teaches and practices full spectrum of family medicine and obstetrics, as well as post-acute and long-term care. We also have Lori Pasqualini. She is the CFO at Ability Beyond, a nonprofit human services organization providing services to over 1,000 people with varying abilities, employing over 1,000 employees. Lori has been working to include employers in healthcare cost conversations, and as a board member on both the Connecticut Business Group on Health and the Connecticut Choosing Wisely Collaborative. We also have Paul Kidwell. Paul is the Connecticut Hospital Association Senior Vice President for Policy, and he came to this role of over a year by way of the Federation of American Hospitals, the Centers for Medicare and Medicaid Services, and Capitol Hill. And finally, we have Lou Gianquinta. He is the president and general manager of Anthem Blue Cross Blue Shield Connecticut. He's newly appointed to the role with just over 3 months under his belt, and has a diverse background in health insurance operations, affordability solutions, and profit and loss management. Lou has worked at several health plans, including Oxford Health Plan, United Healthcare, and WellCare before joining Anthem in January of 2020. Most recently, he served as the president of the Missouri Care, the largest Medicaid health plan in the state of Missouri, where he had a particular success in advancing provider collaborations through value-based partnership models. So thank you all for joining us. And let me start off the conversation with Lou. Lou, if you wouldn't mind, clearly from the data that has been presented and all the indicators, healthcare affordability is a pressing problem here in Connecticut. So what types of actions are necessary to achieve substantial and sustainable reductions in cost growth from your perspective?
Sure, thanks, Luis. Yeah, and just already, just in the few slides we've seen, this is the power of what the cost benchmarking program can do. I'm so grateful that we're doing this in Connecticut, because it does create the right forum, powered with the right data, to have the right conversations on solutions. And Susan articulated the story all too well. it's a problem we have to face and we have to impact, and we have to do it together with all parties involved. It requires a comprehensive set of solutions. There's not one single bullet that takes care of this issue. Certainly, we have to concentrate on the cost of the services, as was indicated. When you see utilization going down and costs going up, that's a problem, right? We've got to address that. So certainly the cost of the services are important. Ultimately, what lies beneath that, which is where this forum can get to, is we have to improve health of our constituents, and we have to improve medical outcomes in order for it to be sustainable. So things like prevention, I mean, it all boils down to prevention. Members getting engaged with a primary care physician, adhering to the medications, following discharge planning when there is an acute service, case management, employers implementing wellness programs, all those things have to be in place for this to have a sustainable impact. All these things are aimed at really avoiding those costly services that we saw on the slide that Michael presented, reducing ER admissions, reducing inpatient stays, especially inpatient stays with complications, and readmissions that those result in. So, the good news is I think we are, I've been in this industry a long time. I've been a part of a lot of collaborations. I do think we are at a tipping point here, and state of Connecticut is on the cutting edge with this benchmarking program. But I also think we're at a tipping point in the payer and provider collaborations that are emerging over the past few years, especially here in Connecticut. We've got we just introduced this year some products that are up to 15% cheaper in premiums as a result of a very, very successful payer provider collaborative called Blue Care Prime with Anthem. And what that does is it brings together a significant number of IPAs that come in with the same goal aligned, which is improving outcomes through the tools and resources and governance that is needed to do that. So I do truly believe that we are making significant progress in those collaborations. And if we can get out of the back and forth on the fee for service arguments and battles that we have, and we can start talking about value-based programs and value-based alignment, and start changing the conversation to improved outcomes that will lead to lower cost, then that's where we need to head. And this collaboration around the cost benchmarking program can help us do that. So I'm full of optimism. We do need to do a lot of work, and we need to do it together, but it's a huge priority of mine and one that I'm standing ready to contribute to.
Great, thanks, Lou. Let me follow up and ask Dr. Alvarez to, you mentioned the provider and payer relationship. So Dr. Alvarez, from your perspective, what are some of the best practices or items that you think would be essential to continue to develop those relationships, not just with Anthem, but with other payers?
Sure, Luis, and good morning, everyone, and thank you for having me. It's a pleasure and it's an honor. So I was particularly moved by what Angela and Susan said. I have a wife who has a genetic and progressively a worsening muscular dystrophy. So I've had a lot of years of actually helping her to navigate the healthcare system, which is quite fragmented. So that this really does, I can tell you, hit home. But from a provider perspective, which is what I bring to the table, we have to remember and keep top of mind that the patient needs to be at the center of everything that we do, right? I mean, that's our North Star, and realistically, who is the patient? It's our friends, our families, our neighbors. It's everyone here that's sitting here. At some point, we have been or we shall be patients. And at Pro Health, I mean, I'm very much into mission statements and vision statements. I can tell you at Pro Health, our mission really is to help people live healthier lives. And our vision is actually to help make the health system work better for everyone. But again, from a provider perspective, how do we actually do that? I think one of the most powerful tools that we have as providers is actually utilizing evidence-based medicine, which has already been mentioned. because there is a lot of information, there's a lot of data now, and it's ever increasing in terms of what is the best way to actually take care of patients. And evidence-based medicine, I mean, it comes down to guidelines that are based upon data that show improved outcomes. And you do that, of course, and you employ those, of course, in partnership with the patients, because in the end, we need to deliver and provide what they actually need, which is effective care. Prevention, Lou mentioned it, is key to that, as well as, you know, the alleviation and ultimately the cure of whatever ails an individual. And we do use that a lot. I can tell you in Pro Health, and again, we are mostly overwhelmingly a primary care group, but we do have and we utilize something called optimal care that Optum provides with us. Again, and it looks at common ailments that individuals have, but what's the best way to actually approach them and take care of them that we know will lead to better outcomes. And we also have an internal paper that our own docs put together called Evidence Matters, because in the end, what's most important is, have we helped people? But the bottom line is the use of evidence-based medicine by providers, and that is an educational process, right? If you ask two doctors how to take care of one thing, you'll get 10 different answers. But actually, there are proven methodologies and treatments that do work. So a lot of education and a lot of working together with the patient that we have sitting right in front of us. So,
Great.
from my perspective, that's the big one.
Any of the other panelists would like to contribute to that?
Yeah, I wanted to also use this opportunity to thank the governor for the opportunity to talk about, cost drivers and try to reduce cost in healthcare. I think that a lot of the actions that focus on the major drivers of healthcare costs are required to bend the cost curve. Such actions really have to include inappropriate utilization, especially of advanced medical technology, lack of patient involvement in decision-making, payment system distortions that encourage overuse. We've heard about the issues of high prices for healthcare services. We need a healthcare workforce that is not aligned with only national needs, but also has to fight against excessive administrative costs, medical liability, and defensive medicine, because we know that more Americans with declining health status and chronic disease, as you mentioned, and a lot of the elderly persons that are entering the demography right now is something that we have to focus on. And I really truly feel that the key policy options that will most likely achieve the greatest cost savings are those that focus on reducing avoidable, ineffective, and duplicate use of services that include not only technology, but also encourage clinically effective care based on comparative effectiveness research and also implementation of information technology. We have to focus on paying appropriately for healthcare services and encourage the adoption of innovative models of healthcare delivery, such as the patient-centered medical home, which is some of the things that Angela mentioned earlier. We also have to focus on ensuring accurate pricing of services. We have to ensure an appropriate physician workforce that is specialty mix. We have to reduce administrative costs. We have to reduce costs for medical malpractice and defensive medicine. And as everyone has said, we have to promote wellness and encourage prevention, chronic care management, changes in unhealthy behaviors, as well as encourage patient responsibility for health and cost consciousness.
Thank you, Dr. Ken Tabibi. Moving on to another topic, because we've had a lot of conversation so far and a lot of comments around evidence-based practices, all leading to quality care, but at the same time with the eye out to reducing costs, right? And as the data shows, utilization is going down, costs are going up. So how do we balance that? I know that a lot of stakeholders in this kind of process, both here in the state and elsewhere, have concerns that, vulnerable populations and or underserved populations, as Angela so well pointed out, may be negatively impacted through this kind of a process. So as we go forward in this benchmarking and implementation, could you please, comment from your perspective on how we can mitigate those concerns and ensure that the right dosing, if you will, of treatment and care is available, and at the same time maintaining the quality and perhaps increasing utilization so that it doesn't get to the chronic stage, which is so much more expensive.
I'm happy to hop in here.
Great.
And just, from the hospital perspective, right? I mean, we have a commitment, all of the Connecticut hospitals, right, have a commitment to provide care regardless of an individual's ability to pay, right? And that shows up in any number of ways, whether you walk into the emergency department, you're managing chronic disease, the level of charity care that is provided throughout the year by our hospitals. For us, the approach of managing the goal of sort of achieving spending growth reduction certainly is based on improving the quality of care, but it's certainly not based on a reduction in providing care to those who need it. That's the mission of all of, I think I'll speak for the hospitals, but I can certainly maybe speak for some of the providers as well. That's the mission. One of the things that that Rachel touched on a bit, Angela and Susan, I think both did as well, is how do we extend sort of the care into the community? So it's more than just preventive health, but it's community health. Where is sort of have that discussion about what the commitment is to affordable transportation, affordable housing, making sure that individuals have access to healthy foods, so that you sort of do that foundational work, so they're not sort of coming to the emergency department for the most expensive care. We know hospital care is expensive for any number of reasons, right? Really valid reasons. We're open 24 hours a day, 7 days a week. I think if you look at COVID, hospitals have served 31,000 inpatient COVID patients, in just over a year, and basically closed our doors for some period of time. So how do we all of us extend into the community to try to improve the health of the community? And I think this conversation is really important because it helps us think of how do you do that in a way that though also can support all the things that we want the healthcare system to do for us, right? And that's the challenge, right? It's sort of to have a conversation about what do we want Connecticut's healthcare future to look like? How do we finance that appropriately? But how do we, number one, make sure patients are healthy? So I think that's as we noted, I think Ben said, the patient's the North Star. And I think all this is wrapped around that.
Well, I love what you said about this, basically the socioeconomic impacts that are hitting some of our members, and the ability for us to work together, payers and providers and hospitals, on how do we combine our efforts to improve public health. I also think we've got another unique opportunity ahead of us here with the American Rescue Act that just was passed, and the additional subsidies that are now available through the exchange, both increasing subsidies for members that have subsidies, and also introducing subsidies for members that don't currently get a subsidy. Those types of activities that are going on right now can penetrate deeper into the uninsured and underinsured population, and get those folks the insurance coverage they need. I also think there's a tremendous amount of education that needs to occur, because there are a lot of people that have access to the exchange and those benefits and don't utilize them. So there is with what was just passed, and for 2 years, we'll have these additional subsidies. We need to take advantage of that as a state and work together to educate the members that they have options for benefits that they may not realize that.
Great. Let me bring Lori Pasqualini in, because as a provider of services for, again, multiple vulnerable populations, I'd be interested in hearing your perspective, Lori.
Yeah, and I have two perspectives, one for the healthcare of the people that we serve, but also as a payer of healthcare cost. Our second largest expenditure outside of employees is the healthcare cost. And it has been a true challenge. Many of the issues that were raised by the consumer advocates who spoke earlier, and the conversations of Lou and Paul, impact the people we serve, but more so the people we employ. They can't get to the doctor during the day if they're working during the day. We see our ER usage high in the evening during the weeks because they either work the overnight or the day shift. So we've got a lot of the same problems that almost all of the groups here are representing. And I see the employers as a key resource to this committee. We have found over the last decade and a half that we can influence our employees' usage of the healthcare system by creating incentives for wellness initiatives, choosing doctors who follow, the doctors who use the evidence-based medical processes. And I think it takes effort by the employers. And I think many employers don't see that they have a role in the healthcare system in educating their workforce. And going back to the people we serve, what we have learned is when we educate our workforce on their own health, they carry it over to the people we serve's health, and it's a double benefit. So there's a lot that I think can be done in collaboration with the employers, the healthcare companies, and the providers. And we've tried to do that for decades, mostly because I've got a background. I worked at Bridgeport Hospital a couple of decades ago, and I understand the relationship of those pieces probably more so than most CFOs.
Great, thanks, Lori. Let me ask you, because you mentioned employer role, right? And I don't think that that's often something that is touched upon enough. And I'm wondering if the Office of Healthcare Strategies could play a constructive role in terms of facilitating, that partnership that is not just payer and provider, as Paul and Lou and Dr. Kentabibi explained, but can you elaborate a little bit on what role OHS could have in terms of lowering, the efforts to lower costs with employers?
I think one of the critical components to get these costs down is to identify what is the benefit and what do each stakeholder gain from this effort, and what does each stakeholder have to do in order to achieve that benefit. And I think the employer needs to be considered a stakeholder, particularly those who have health coverage. But even if you don't provide health coverage, illnesses for the workforce is a high cost item, absenteeism, workers' comp claims. So it hits the employer in more than one way than just the healthcare cost that is our largest cost, but workers' comp is right there behind health insurance. And absenteeism is a very high cost factor for most employers. So I think bringing the employers to the table, identifying what's in it for them in terms of what they can gain and what they will need to do in order to get the positive impact. I think those are critical aspects of how the Office of Health Strategies could engage the employer community.
Yeah, Lori. Lou, any? We'll move on to Dr. Kentabibi, but Lou, from a payer perspective, what would you, what are some of the strategies that you use in terms of engagement of employers and strategies as Lori has mentioned?
Well, I mean, certainly in the aspect of evaluating their costs, particularly to their group, and what some of the trends are that are hitting that particular group, because each employer may be different in the types of issues that are affecting their cost. So what we do is we work with our employers to analyze their data specifically, and we have pretty much a toolbox of various programs and value-based value-based initiatives we can bring to the table to address their specific needs. And so that's number one. Number two, we try to encourage our employers to implement wellness programs to impact the base health of their employer groups. So those are some of the things. But I think it starts with the data, and just like we're doing here today, you have to do that deep dive by the employer by employer, to determine where they're most vulnerable on the cost side. And then, use our power at Anthem to bring the right solutions to the table, particular to that group.
Great. Dr. Kentabibi, you wanted to contribute to the conversation. Sorry, I cut you off.
That's okay. Yeah, so, I was glad to see that the initial data was showing the importance of primary care. And one of the focus of the Office of Health Strategy is to try and move that number in terms of reimbursement to 10%. One could say that the system is broken, even though no individual is at fault. But there is a lot of evidence that healthcare systems with a strong primary care base, whether it's 90% primary care with 10% specialty care, for example, tend to have lower costs and more efficient systems. If you go back and look at the 30 plus countries ahead of the US in healthcare outcomes, they have two features in common. Whether it's universal healthcare and a strong emphasis of primary care, which we have to, not pointing fingers, but we don't put enough funds in addictions, mental health, kids, immunizations, chronic disease management, and public health. And I may beg to add here, COVID, as we need to. So we continue to have a reverse pyramid where all the best countries have a pyramid with primary care as the base. I think that we have to continue bolstering primary care and supporting initiatives that primary care can support to reduce healthcare costs. For example, Angela mentioned care coordination. We have to look at things like home visits, home births, with home birth network and hospital care at home. We also need to have, like everyone has said, have all the stakeholders working together, and the focus should be on patient-centered care and overall what is best for the patient. And at some point, start to look at the whole issue of malpractice and liability, which will help to reduce provider fear of missing unlikely diagnosis. And I'm hopeful that when all the data is analyzed, some of the things that I mentioned as drivers will pop up.
Dr. Alvarez,
Yes.
And then I'll move on to you, Paul, because I want to get Dr. Alvarez's perspective as well,
Yes.
and from a provider perspective.
Sure. So primary care is where it usually all starts. When a patient needs something, that's who they call. And these are providers that are in their communities. They usually interact with each other. Their children go to the same schools. From what I have seen, not just here, but elsewhere in my sojourns throughout the country, primary care is quite the foundation. They are also extraordinarily important, not just for taking care of patients, but also in terms of educating them and also coordinating what needs to happen with that patient, right? So I think what's happening here, again, this is another great example of what OHS has led and brought to bear is that we have all the stakeholders represented. We are collecting the data, as has been mentioned already thus far, which is very important. This is a data-driven approach to actually dig into what are the drivers of cost. Because again, from a provider perspective, what I'm looking for, and because we're the ones that are literally in the room with the patient, directing them and helping them, is really what are the trends, right? Where are things going? What are the populations that are at risk, so that we can apply focus to that and resources to it. So yeah, from my perspective, it's primary care is where it starts and ends. And I will mention something that that Paul had, I think, alluded to. So often I have a conversation with people that are not in the medical field, especially my mom, who thinks that she is. But when I talk about affordable care, she's always like, "Oh, that's cheap care." And it's like, "No, Mom, that's not cheap care. That's actually better care." But that is the perception that's out there that I think we have to again educate, and usually that's on a one-to-one basis, with individuals, docs in the office, with their patients. Also, we're not talking about cheap care. We're not talking about you getting less care. We're talking about you getting more care that's the right care, right, at the right place and at the right time. So
thank you, Paul.
Yeah, so and this is one of the, in thinking about everyone at the table, I think one of the challenges will be is who is not at the table. I mean, today is Medicare and Medicaid as very giant payers of healthcare, right? And a growing percentage. And what those two payers do affects how everyone else acts. And so I think we just have to be aware that that's a challenge we're going to have to work through going forward, because we need to understand, number one, their data. And then two, there are things that are going to be outside of our immediate control. And so, that has a very real impact on how this proceeds, because it's all going to be assembled and judged as far as reaching the benchmark. And so how do we bring those two payers into the discussion, I think is really going to be important going forward.
Yeah, good point. And while not represented here today, certainly they have been part of the process and providing input and I think that I think it's been a really good strategy to ensure that both the public and the private payers have the same benchmarks, so that no population will be affected negatively based on that. One may have more work to do than the other, or vice versa, but we'll see as we move forward. We have just a few more minutes, and we touched upon this concept of stakeholder collaboration and shared accountability. Accountability is not a four-letter word. Let's not use it as such, because I think it's important not only that each of these systems hold themselves accountable, but that there's again a process that is informed by data and by outcomes. So if you could kick off last comments around this and that concept, and then we'll go down with others.
I'll start if you want.
Sure.
I think first and foremost, we all have to admit that we play a role and we have some culpability in making this successful. We have to agree on some basic concepts that at the end of the day, we have to drive costs down and we have to improve outcomes in the health of patients. And we all have to figure out how to get there together. And then we can start constructing the right programs and initiatives to have the impact.
Yeah, I will say, what OHS, the framework that OHS has set up, has been really helpful to get all the stakeholders sort of in one place over a sort of sustained period of time. So you have ongoing discussions with each other around some tough questions and discussion items. And I think that also helps us, sort of going back to something I said earlier, is what do we want this to look, sort of what do we want the shared vision to look like, right? What do we want this to be. And then, as Lou noted, then you can start making the some of the choices and decisions to get there. But starting from a position of what do we want this to, what's our shared vision, I think has been very helpful.
Dr. Kentabibi, any final words?
Yeah, I think that in addition to including all the different stakeholders, that, as everyone has said, payers, economists, academics, everyone should be on the table and do some research into the specific areas that we have concerns in. But we also need a lot of investment in health and the determinants of health, looking at other issues like early childhood education, recreation, fair and affordable housing, occupational health and safety. I think that patients and families should be part of the stakeholders, and having standardization of care and using evidence in everything that we do certainly will continue to go a long way.
Thank you. Lori, and then Ben, please. And we're almost out of time, if not out of time, but I don't want to leave you guys out. Is that okay?
Yeah, thank you. Lori?
I think one of the key things that will contribute to success would be having some leading indicators to measure that are distributed timely and almost real time, so that people can adjust to what is working and what isn't working in real time as opposed to years later. I think that is a key component that we need in any system that's put forward.
All right.
And
sure,
yeah, go ahead.
And I'll add, I already have walked away more enriched from this conversation with all of you. I mean, that's the beauty and the magic of it. But I think we start right with a common appreciation. Again, it's about the patient and the patient at the center, and whatever it is that we do, because we're all part of this ecosystem, it's got to make the system work better for everyone, and it's got to be a good experience also for the patient. Less fragmented, it's got to be easy, and certainly less frustrating. But I'm very hopeful. Really enjoyed this.
Wonderful. Thank you. Thank you all so very much for joining us today and providing your insights into this conversation. I'll just say that as a clinician, whenever I do therapy, it is always important to stress that any relationship or any work around relationships and building relationships has to assume positive intent so that you can enter into that conversation. So again, thank you all for your participation here today, and I'll turn it back to Vicki.
Thank you so much, Louise. A very inspiring last statement, which I think our panel showed the positive intent and the desire to work together. And we appreciate your participation today and your moderation, Louise. I want to close on this note. I think this is a good note of collaboration to close on, and shared accountability. That's the core of our efforts in undertaking this cost growth benchmark and other related initiatives that we work on. Through transparency and the use of data, it's really our goal to work together with stakeholders across the continuum. That includes patients, people like Susan, people like Angela, and other patients and payers, providers, hospital systems, business, industry, pharma, to come to a common understanding of the real cost drivers in the system and work together really in partnership to find ways to address them. I know we're up to this challenge of having hard conversations, as Paul mentioned earlier, and the creative brainstorming we're going to need to find these sustainable solutions to make the system work better for everybody and to improve our primary care performance, be more affordable, and ensure better quality for everyone in our state. I do want to take a quick note or a quick second to thank my team at OHS for helping to put together this forum and making it work so smoothly. And finally, we all look forward to the work ahead and welcome any of you watching to contact us with any of your questions or thoughts or ideas. And you can see the address at the end of your screen and at the slide on your screen right there to Krista. So thank you all very much for joining us today, and we look forward to continued engagement with all of you. Thank you very much. Take
Thank
care,
you.
everybody.
Thank you.
Thank you.
Thanks, Vicky.